and she is going to speak on optical blunders in IOL calculation. Dr. SHRUTI KOCHAR.
Thank you, Dr. Rohit sir, for the opportunity, and a very warm good afternoon. I'll be speaking about 10 situations where we make optical blunders while calculating the IOL power. This is what I learned in my fellowship at Narayan Nethralaya, and I have no financial disclosures to make. In 1990s, the major cause of refractive surprise post-operatively was faulty axial length calculation. But in today's era, it is the effective lens position prediction. So to battle refractive surprises, what we need is precise biometry and accurate IOL power calculation formula. And all the formula aim at increasing and improving the ability to predict effective lens position. So here's the situation 1 where we have poor cornea and poor ocular surface. So before taking measurements, be very sure that the patient removes the contact lens. Very simple tip, but it's really important. Soft contact lens at least 3 days prior, toric a week prior, and RGP a month prior the measurement. Make sure that the ocular surface and tear film disorders as well as punctate keratitis and other dry eye diseases are treated well before biometry and the surgery. Even a 1 diopter error in the measurement can cause 1 diopter error in the refraction post-operatively. So here is pterygium case where grade 1 and atrophic non-progressive pterygiums can be operated in the first go. However, a grade 2 or larger pterygium needs a stepwise approach. Pterygium causes flattening in the horizontal meridian, and if it is affecting the astigmatism, it is better to operate a month prior the cataract surgery. Here's situation 2 where we have dense cataracts. In these cases of 70-year-old gentlemen, we failed to obtain axial length using conventional optical biometers. So here there are 3 options. Go back to ultrasound immersion technique, or use dense cataract measurement mode in LensStar, or we can opt for IOL Master 700. So what are the machines available today? They are based on 3 technologies basically: partial coherence interferometry, optical low coherence reflectometry, and swept source OCT, and here are the examples. Here's a chart where I've compared the available optical biometers and their additional features. I can share it with you later. This is a published work of Narayan Nethralaya where we saw that IOL Master 700 has better penetration in dense cataracts and there are fewer dropouts in axial length measurement. So here are few quick tips for good axial length measurement. The standard deviation greater than 0.2 indicates a problematic reading. The signal to noise ratio can go high as much as 12, but anything less than 2, we should discard those axial length readings. And take time to verify all these readings yourself and keep tracking your own outcomes. Here's the latest Biometry OCT. It is an innovative method using the posterior OCT devices to measure the various details of the eye. So here's the picture showing beautifully dense cataract in high myopes, even in retinal detachment and macular holes. So you can visually verify where do you want to place the cursor to get the accurate measurement. Coming to the big challenge in biometry, post-refractive surgery. Like here is the scenario of 55-year-old female who presented with cataract. She had underwent LASIK some 27 years ago, but we do not have her any previous record. Her topography shows well-centered ablation. So what do we do in this case? In post-refractive cases, the ratio between anterior and posterior is disturbed. So optical biometry is not very good in such cases. We can go to ASCRS online calculator, use 65% mean keratometry with 0 to 4 mm zonal equivalent keratometry value from the topographer and calculate IOL power. So studies have shown that ASCRS minimum value, minimum should be considered most accurate in such cases while calculating the IOL power. However, for post-RK biometry, it's better to use average or maximum value what the calculation suggests, because there is hyperopic shift post-operatively. Coming to posterior corneal astigmatism. While doing toric IOL, if you ignore the posterior corneal astigmatism, it can result in overcorrection for with the rule astigmatism and undercorrection for against the rule astigmatism. So various options available are the Baylor nomogram. However, it is little cumbersome to use. Now, even the manufacturer-based calculators have incorporated posterior corneal astigmatism, and even online calculators like Barrett's are very useful. Coming to situation 4, where we have corneal ectatic disorders. So how should we go about such cases of keratoconus, pellucid marginal degeneration, post-LASIK ectasia, and decentered ablation? Be very careful in reading topography in such cases. Always make sure that where the cone is located, is it central or is it peripheral or is it the bisecting cone where it comes in the visual axis? Such cases are really tricky. What is very useful in such cases is Pentachem Holiday EKR report. It is helpful in deciding when to implant toric IOL. If the decentered profile is stable and it's not progressive, and if the Holiday EKR shows that the graph is single peak and tall, there is very likely that it has variation in the keratometry in the central 4 mm zone, and in such cases, toric IOL is a good option. So you can see the EKR readings from 1 to 4.5 mm zone does not vary more than 1 diopter. However, if the variation is more than 1 diopter, the graph is flat, monofocal should only be planned in such cases, and toric IOLs should be avoided. Coming to another situation where we have had previous retinal surgery like silicone-filled eye, or we are planning a combined phaco-vitrectomy. In such cases, it's better not to use contact method. Any optical biometer is good in such cases. But when there is a combined silicone oil removal, it is better that we go for newer options like intraoperative retinoscopy. However, the results are little limited in such cases. So coming to most important question for routine hyperopia, high hyperopes and high myopes, what do we do? So there is new classification of formula where regression analysis like SARK and SRK2 are a little outdated. We have new versions formula like 2 variable, 3 variable, 5 variable. The 5 variable is Barrett Universal 2, which is very good. And the 7 variable, even Holiday 2, is good for all kind of axial lengths. Newer formulas are artificial intelligence based like Hill RBF, Clark neural network. And we have latest ray tracing formula, the Oculix and the phaco-optics. All of these ray tracing, artificial intelligence hold good for all kind of axial lengths. Coming to irregular cornea. So this is a work published by Narayan Nethralaya where we plan to regularize the corneal surface before cataract surgery using topo-guided customized ablation. It stabilizes the post-op topography, and after regularizing the surface, the IOL implantation is performed and the results are pretty good. Here are some newer concepts like ray tracing, where we use the pre-op IOL position and the dimension of the crystalline lens to predict the post-op ELP. It is very helpful in calculating IOL power using ray tracing technology. Also, another concept is corneal asphericity, which should be taken into consideration before implanting an IOL. More prolate, that is more negative the Q value, there will be a negative prediction error while calculating the IOL. So there will be a myopic post-op refraction if you operate such cases with high corneal asphericity. And last, the most talked about topic, the intraoperative biometry. The available options are the OptiWave refractive analysis system, the ORA, and the other options are HOLOS and Aston abrometer. It gives us the opportunity to double check the preoperative findings, but again, it is an expensive tool. Intraoperative changes like vitreous hydration are not taken into account, and even the corneal shape can get distorted once we put the speculum. So the effective IOL position prediction is little tricky in such cases, and the number of unsuccessful scans are little high. Lastly, I would like to say this is the future of biometry, where we can do intraoperative OCT, and it will definitely decrease the IOL prediction problems. But this technology is again demanding, and it is little manual, not very automated. And other problems, as I said, are vitreous hydration, and iris capsule contact needs to be separated in such cases. In the end, I would like to conclude by saying that with modern measurement techniques and better formulae, hopefully in future we'll improve the prediction and achieve better ELP and axial length as well as the keratometry. Thank you so much.
Any questions for Dr. Shruti or any comments on this?
For cyclotorsion, sir? Squint.
I think squint is what he said about.
Yeah. So few cases of squint, if you don't take care, then there are chances of miscalculation of IOL that you have not mentioned.
Right, sir.
So
It can definitely be a source of error.
yeah,
Yes.
and especially in cases of where the cyclotorsion is there, either inferior oblique or superior oblique is
So
involved.
preoperative marking as well as on-table marking in such cases can be helpful.
Yeah, so one have to be cautious, especially while asking patient to see at particular point, because of that fixation is not that proper. So please,
Yes,
that
sir.
has to be made.